a surgical procedure of feline perineal urethrostomy. Sandy, our patient here, has been through several episodes of urethral obstruction in which he was managed with medical management and nutrition. These have repeatedly failed, and he is reobstructed and today will require surgery. Sandy has been premedicated with acepromazine ketamine, anesthetized with isoflurane, prepared for surgery, and positioned over the end of the operating table. He has been draped with 4 drapes. A purse string has been placed in the rectum, and the surgical field will be the area from the rectum to below the prepuce. We will complete our draping by placing a final drape over the operating field. Our landmarks are as follows. We would like to reposition the urethral opening so it enters at the level of the pubis. The pubic level is here. So the top of our incision will be at this point where I put the stab wound. We will carry that incision around and underneath the ventral part of the prepuce there. The incision itself will resemble an inverted teardrop, being slightly narrow at the bottom and wider at the top. This incision being made on the right side of the prepuce and reflecting the prepuce the opposite side and making the opposite incision as a mirror image of the first. Those 2 incisions should have come together at the top and at the bottom. We will then bluntly dissect this skin free. There are normally a couple of small vessels that may have to be ligated as you make this skin incision, freeing up the subcutaneous fat, establishing a plane of dissection as you go, reflecting the skin to the opposite side, and as you can see here, I'm making the plane of the subcutaneous tissue and making that incision. It's important to be careful at this point that you do not transect the penile structure, since that will be done at a later point. Subcutaneous fat and fascia is excised. You can see the base of the penis starting to be exposed at this point. What we want to do now is go ahead and remove all the skin of the scrotum and the prepuce. If this cat had not been previously castrated, we would castrate him before we began. However, you can tell here the old scrotum is shrunk because he was castrated several years ago. We'll continue our dissection, freeing up all that skin. Including the fat and fascia around the ventral part of the prepuce. And just roll this skin right off the end of the penis and transect it. Sometimes this is easier done by using a scalpel and carefully dissecting with a scalpel. There's the penile structure there. We do not want to cut it. We want to roll the skin right off the end. Until you can feel that you have come past the end of the penis. Then you can transect the entire structure. Get a better view here that we've got some fascia ventrally, which needs to be cut free. I can go back to the scalpel now and continue to remove all the skin. When you feel you're past the end of the tip of the penis, you can just simply take the scalpel and transect. There's the end of the penis, so I've missed it, and remove all the skin and fascia. At this point, to keep my anatomical landmarks correct, I like to take a hemostat and tag the prepuce at the very most ventral position. Also, since you're commonly doing these unassisted, I find a Gelpi retractor very handy to retract the skin. Placing the Gelpi retractor, and that opens up the surgical field to where you can see your anatomical dissection. There normally is a couple of small bleeders at about the 8 o'clock and the 4 o'clock position that had to be clamped here and here. On this particular cat, those are not visible. Therefore, we will continue our dissection. We need to free up the base of the penis so we can find the ischiocavernosus muscles and dissect them free from their attachment at the pelvic brim. And you can see one of these muscles right here. This is the ischiocavernosus muscle that attaches the base of the penis to the brim of the pelvis. We're going to dissect completely around that muscle, and we will transect it, and then we will also find the opposite muscle so we can completely free up the penis, and that will let it be exteriorized caudally to free up the urethra within the pelvic area. Blunt scissors or a curved hemostat works best, working around the top of the muscle and around the ventral aspect. This is a point where you can make a mistake that you do not get completely around that muscle. It's essential that you get that entire muscle freed up. Do not leave any muscle strands at all. I'm completely around that side. You can see my instruments now coming around the bottom. That muscle is completely freed. And now then, I will put a clamp on that muscle because there's a small artery inside the muscle. So I'll clamp it for a minute so that will aid the hemostasis. Has some oozing from the edge of the prepuce. Now we'll go to the opposite side and do the same thing to the muscle on the right. You get a pretty good view here of the opposite muscle coming into view once the fascia, subcutaneous fat and fascia, is freed up. You can see this muscle now starting to become visible. I'll go back to a blunt hemostat so I can get around behind this muscle as well. And dissecting between the muscle and the brim of the pelvis. We've noticed in recent years we're doing fewer and fewer of these surgeries because many animals respond medically, and we do not find ourselves having to do this surgery quite as often. However, some cats, such as Sandy, are continuing to obstruct despite the best medical management we have, so we are finding ourselves having to do this surgery periodically. So I've now isolated both ischiocavernosus muscles, completely free at the pelvic area. I have put a crushing clamp across the muscle, and we'll leave that on there for a few seconds, while I free up the ventral part of the penis. Here is the entire length of the penis. Retractor peni muscle lies right on top here, and I'll go ahead and remove the retractor peni muscle. On an intact male, this muscle is much more obvious. On this particular cat, the retractor peni muscle is quite atrophied. He was castrated several years ago. We have now had a minute or so for those muscles to be crushed. I'm going to take the instrument off and take a pair of scissors, and I will cut through that crushed area of the muscle so that I can free up that muscle completely. Be sure that you completely cut that muscle. Here is one end of the muscle. Here's the opposite end. Completely cut that muscle. You can see that little artery now in there starts to bleed a little bit right there. If necessary, you can put the clamp back on, or if you have cautery, you can take your cautery and touch that bleeding spot. I'm going to put a small clamp back on that spot. And take the opposite clamp off and transect the opposite muscle. This side bleeds a little more Obviously, if it bleeds much, you can simply take a gauze and put a gauze pack in it for a second. Or, as I mentioned, take cautery and cauterize them. Now, it makes the manipulation much easier if when you're working on one side to retract the penis to the opposite side so you can retract it back and forth as you work. Once you sever the two muscles on the left and right, then your next attachment is a ventral attachment, and the ventral attachment is a fascial attachment to the pelvic floor. And here is a fascial band on the pelvic floor that attaches the penis to the pelvic floor, and those are cut. You can palpate with your scissors and feel those bands and carefully cut those. You can see that as I cut that last band, the penile structure retracted caudally. To be sure you've completely severed all those attachments, it's best to take a hemostat and feel underneath the penis and the pelvic portion of the urethra to see if there's any band of attachment left. And I can feel one band here. You can't see it, but you can feel it. So as you feel those bands, take your scissors, band right there, and snip that band. See how that one pull loose? Now, palpate on both sides. This side, any attachments left here? No attachments left on the left. No attachments ventral. No attachments on the right. So now then, the only thing left attaching the penis to the pelvic portion of the urethra is the urethra itself. I do not believe you should do the digital dissection where you take your finger and completely ream the pelvic area. I have seen several cats who had complete incontinence of urine secondary to pelvic reaming. I believe if you do not ream the pelvis, you will not have that problem. Our dissection is complete now by freeing up the urethra, and we're ready to incise the urethra from the tip of the penis to the area of the pelvic urethra itself. A good landmark to use in this incision is you need to be with your incision well above the ischiocavernosus muscles, which are here, and normally to the level of the bulbourethral glands. This cat's been castrated several years ago, so the glands themselves will be quite difficult to see. They'll normally be embedded in this fat at this level. I prefer to do this surgery without a catheter in place. Sandy was previously catheterized and the bladder drained, but I like to open the urethra without the catheter because the catheter gets in my way. I like to hold the hemostat holding the prepuce in my one hand and then insert the blunt tip of a scissor into the urethra and make small cuts so that I keep my scissor all the time in the urethra, never losing the urethra, and continue moving the scissor up the urethra as I go. Sandy has been catheterized several times in the last couple days, so the urethra is quite small and swollen, and the scissor doesn't go very easily. He's also castrated several years ago, which makes the urethra somewhat different from an older intact male cat. I'm going to continue advancing my scissor, making small cuts up the urethra until I get to a large diameter of the urethral opening. I'm up almost the level of the glands now. I made one more cut. Something I like to use as a gauge to determine if the opening is big enough, I like for a hemostat to be inserted in the urethra to an area of about a 5 millimeter diameter, which will be about this big on the hemostat. So slide the hemostat up the urethra and see if you have an opening that is approximately this diameter. This hemostat will go up the urethra easily to the area of the box lock, which means I have about that much lumen. Once you cut through the penile structure itself, you start getting some bleeding. There's no way to avoid that, but you want to make sure you've opened up the urethral lining. And you can see the opening of the urethra as a shiny membrane, and that's the area that you want to suture. At this point, we're ready to start our suturing, and I take a 4/0 nylon monofilament suture and place the first two sutures at about the 2 o'clock position and about the 10 o'clock. Taking and opening up the urethra so that you can see the lining of the urethra, and place the first suture through the urethral lining, out through the edge of the penis, and out through the skin at about the 1 to 2 o'clock position. We want to open up the urethral opening first. Place the first one. I like to tag it with the hemostat and lay it off to one side. I'll then take a second suture, just like the first, and place it on the opposite side. Again, I'll come through the opening, seeing the urethral lining, pick up the urethral lining through the edge of the cut, through the cut edge of the penis, and out through the skin at about the 10:30 or 11 o'clock position. Also take this one, tag it with the hemostat, and lay it off to one side so that I can see if I like the placement of the first two sutures. If this has been done right, the first two placements are right, this should open up the urethra so that you have a nice opening right through the pelvic urethra. That placement looks okay, so I'm going to tighten those two down, and that will be my first two sutures. Nylon sutures, 4/0, placing 5 to 6 throws on that nylon because it does not hold sutures well. The nylon does not hold knots well, so multiple throws are done, and we will cut those about 5 millimeters long. We'll then take the second suture and tie it. We may decide when we look at this that we want one suture at the 12 o'clock. I'm starting to get a little bit of a pucker up there, and that may influence me to put one suture at 12 o'clock position. We're now going to make a drain board on the sides of the urethra, and this will be done now by releasing our Gelpi retractor and coming down the sides of the urethra. Need to sponge some of that blood off so we can get a better view. Because it's important here that we pick up the urethral mucosa as we suture. These sutures be placed through the urethral mucosa. There's a shiny membrane right here, through the cut edge of the penis, and out to the skin on the lateral side, so that we suture the transitional epithelium of the urethra to the skin. We'll place about 5 or 6 sutures on either side in order that we produce a drain board about 2 centimeters long. We'll alternate these, one on each side as we come through here. Still got some oozing. Of course, when you transect the penis, you're going to have oozing. Again, through the urethra, mucosa, out through the side of the penis, and through the skin. You notice I've not used any subcutaneous sutures at all. I don't find it's necessary to use those sutures in the sub-Q. They create additional inflammation and swelling, which is exactly what you're trying to avoid. These sutures are placed snug but not tied too tight, so that they do not cause excessive irritation. Some people, and I have done it on some cats myself, is use a continuous suture down each side. Makes it easier to remove. However, experience has shown me that the interrupted sutures work best. We've completed suturing now by placing about 4 sutures on either side of the drain board, being extremely careful that we catch the urethral lining and suturing it to the skin. The thing I do not like at this point is that the top of the opening is not opening up well. So I'm going to place one suture at the 12 o'clock position, place a hemostat in the opening of the urethra and spread it open. I'm going to place one suture picking up the top of the urethra and coming out and picking up the skin so I can hold that urethral lining. I'm going to have to do this in 2 passes because it's too thick for the small needle. Coming through the top of the urethra. Now I'll come out the skin at the 12 o'clock position so that by pulling this suture down, hopefully that'll open up the, will hold the opening better. Takes away that pucker at the top and holds the urethral opening in a position much better. So here's our opening at the urethra now, and we have a nice wide opening, about a 5 millimeter opening. The rest of the penis is not needed. We have a drain board about 2 centimeters long now, and we're going to transect the rest of the penis. However, it's a very vascular structure, and if you just transect it, it will bleed for several days. So I'm going to take one suture and go through the edge of the penis on one side. I'm going to use this more or less as a tourniquet suture to stop the bleeding. I'll go through the one side of the penis, back up through the opposite side, and just barely catch the edge of the penis on both sides. And then I will take that suture and tie it down fairly tight. And this will kind of act like a tourniquet and will occlude all the cavernosum structures of the urethra and the penis both, so that bleeding won't occur. That suture will come out, of course, in a couple weeks, so I'll leave it where I can find the ends. Then I simply pick up and transect the penis just below that one suture, and if the suture worked, there shouldn't be any bleeding. Now, what I have to do is complete the rest of the suturing, as of course I have an opening down here at the bottom, but I want to show you how to hide the end of that cut end of penis. And the key there is start just below the cut end with a suture 3 or 4 millimeters below that point, and this will help to retract the penis ventrally and keep the drain board stretched out. Come through the skin on one side, then come through the cut end of the penis with that suture through the corpus cavernosum structures, and this will help to bury that little stump end underneath the skin. And then we'll come through the skin on the opposite side, again 3 or 4 millimeters below the level of the excision, and tie this one down, and this will bury that little end underneath. If you leave that end sticking up, it makes a granulation wound, and you'll have a large mound of granulation tissue that will form in the next few weeks. We've completed our surgery now by closing the wound at the ventral edge of the incision. These sutures will all stay in for approximately 10 days, at which time healing will have occurred and we'll have a nice drain board and a nice opening. At this time, we will remove the purse-string sutures placed in the rectum. The aftercare on Sandy will include antibiotics for about 10 days. We'll also put him on acidifiers to keep the urine acid and try to prevent the recurrence of struvite crystals. Part of the problem of this surgery is the formation of strictures at the surgical site. One way to prevent strictures is to prevent the cat from licking at the surgical incision. The way I like to do that is to use an Elizabethan collar on the cat until the sutures are taken out. I prefer to use x-ray film over the commercially available collars. Take 11 by 14 piece of x-ray film, cut it in a circular fashion, cut a small hole in the middle, and line it with tape so that the edges are not sharp and do not cut into the neck. This is then placed around the cat's neck. Sandy is still asleep, and we'll be waking him up in a few minutes. Place the collar around the neck, overlap it to tighten it until you have enough room for one finger between the cat's neck and the collar. Once you have that proper tightness, take a regular desk stapler and staple it in 5 or 6 spots to hold the collar in place. This will then prevent the cat from being able to lick. The proper size collar is one that would extend out past the nose approximately 1 to 2 inches, as our collar here does. You can tell that during surgery, Sandy has been on IV fluids and will continue on fluids until he is completely recovered.
Glaucoma is a sight-threatening disease in animals that is often overlooked or misdiagnosed. Dr. Dennis Brooks demonstrates current techniques for diagnosis and treatment of glaucoma in dogs and cats.